Hello everyone and welcome to your GI Module 2, where we are going to talk about things that can occur in the lower GI system. So pretty much from any part of the intestines through to the rectum. This focuses on chapter 47 in your book, which is Management of Patients with Intestinal and Rectal Disorders. Some of the disorders we're going to talk about are bowel obstructions. We're going to talk about irritable bowel syndrome and specifically the inflammatory bowel diseases that encompass this syndrome. That'll be your ulcerative colitis and your Crohn's disease. We'll talk a little bit about appendicitis, some bowel perforations, peritonitis. We will cover diverticulitis and diverticulosis. And then we'll also talk about some intestinal cancers. We'll start off by looking at bowel obstruction. So a bowel obstruction is essentially when food or stool cannot move through the intestines. It can occur at any part of the intestines. It can be partial or complete. If it's a partial obstruction, the client might still have some like liquid or very small pieces of stool that they're able to pass. But if it is a complete obstruction, then nothing is coming out. They are not having any bowel movements. They're not passing any gas, nothing is moving through. A complete obstruction can be from a couple different reasons. There can be, maybe there's a gastric cancer that's present that has grown to the point that it's obstructing movement. Any of the mechanical obstructions where there's a part of the intestines that is kind of folded in on itself or twisted. In the picture, the B, that is an example of when the intestines kind of twist on itself. This is a medical emergency. That twisted bowel has no blood supply. It needs to be taken care of rather quickly. There can also be where some of the bowel kind of herniates into the testicles in a male. That can cause a mechanical obstruction as well. There are sometimes medicines. We know there are a lot of side effects for medications, can cause some constipation. That can eventually lead to a bowel obstruction. We can also have dehydration if the client isn't drinking enough water. They can have an obstruction that way. So it really just kind of depends on the history leading up to the event, how long maybe it's been since they've had a bowel movement, how much are they moving around. Those kind of things can all kind of precede a full-on bowel obstruction. So what do these clients look like when they present to the hospital? They're going to have some cramping pain. It could be pretty severe. There also could be vomiting, depending on the severity of the obstruction and the length of time they've had the obstruction. If they have continued to eat food and they are not passing anything, that food is eventually going to come out. It's a thing called fecal emesis, where they are actually vomiting fecal matter because it is backing up so much that it's coming up into the stomach, and then they will vomit it out. They may or may not be able to pass, if it has a bleeding component to it, you may see some blood, small amounts of blood pass, or they may not be able to pass anything, no stool or anything can come out. Depending on the location of the obstruction, we know that the intestines are responsible for a lot of fluid absorption. So if the intestines are blocked and they're not moving stool through, then it's very easy that the client will become dehydrated because they are not reabsorbing fluid. This is also going to lead to some electrolyte disturbances. So we're going to need to monitor those fairly closely. The easiest way to diagnose this is going to be through an abdominal x-ray. That's going to show essentially what's going to look like a megacolon, where we just have parts of the colon that are dilated because of the amount of fecal matter that is present in that part of the bowel. So that's going to be the first line and least invasive. If we're concerned about, maybe a functional, where the intestines have kind of, turned on themselves or flipped in on themselves, we would want to do a CT with contrast because that will help light up any areas of obstruction. And then blood work is going to help us to determine, baseline electrolyte status, fluid status. If we're worried about any infection component, those are all going to be important diagnostic tools that we're going to use in determining a bowel obstruction. So here in this picture, it might be a little bit difficult to see, but the big white area is essentially an obstruction, or that is the stomach that is distended. My apologies. The stomach distended because there's nothing passing through the bowels. It's hard to see the actual obstruction lower down on the x-ray, but we have to decompress this stomach. So we're going to put in an NG tube to get all those gastric contents out and decompress any air that's in there as well. If it is a surgical, so the bowel is twisted on itself or something like that, then we would need to do a surgical intervention. Sometimes they'll have to go in and remove the stool if it is severe enough. Moving on to irritable bowel syndrome. These are chronic functional disorders. So this is the way that the bowels will actually work, sometimes having that intermittent or recurrent abdominal pain. And then they will have a lot of stool irregularities. They'll go from constipation to diarrhea and then back to constipation, or some normal bowel habits. So they'll have normal bowel movements in between. With IBS, women are 2 times more likely than men to develop IBS. And then it's fairly common in our Western populations. Essentially, there are segments of the intestines that are affected by IBS. It's not the entire bowels. It's just segments here and there. And these segments are really what kind of propel fecal matter forward and cause those incidences of diarrhea, to where stuff just moves through a lot faster. It's called irritable bowel syndrome, but it's not inflammatory bowel, because if you take a look at the tissue when they are having an exacerbation, there isn't really any evidence of inflammation or tissue changes, but they still have some of the symptoms of an inflammatory process, because they'll have the diarrhea and other symptoms like that. But really, not quite sure why some people end up with IBS and some people do not. There's possibly a neuroendocrine dysregulation that will lead to it. There also could be an infection. If you have a patient who goes on antibiotics for quite some time, they can maybe end up with a form of IBS. There also could be a blood supply issue, so whatever vascular supply. If there's a richer supply to one area of the bowels, they might function a lot better than the areas that have less of a vascular supply. There also could be some metabolic disturbances that maybe could cause the IBS to be better or worse in different people. So again, the cause is unknown. Some of the clinical manifestations that we're going to see, they can vary widely among different people. Some patients may have very mild symptoms. They know they're offending foods. They know what they can and can't eat. But even sometimes the foods that they consider safe for them, they could have an episode of multiple episodes of diarrhea, because for some reason this time their body did not like whatever food that they ate. But generally speaking, we could end up with some abdominal pain. They could have some excessive flatulence combined with the diarrhea. There also could be constipation. They're going to have really this alteration in bowel patterns, going from constipation to diarrhea. And they really could either be one or the other. If they are a primary constipation with irritable bowel, then that would be their primary component, where they could also be have diarrhea as their primary issue, which then that would be their primary. So it would be irritable bowel syndrome with the diarrhea component. Or they can be super lucky and have that true alteration in the bowel patterns where they flip from constipation to diarrhea and back and forth. Symptoms can be the same. There's going to be pain, there's going to be bloating, there will be urgency to get to a restroom to have that bowel movement. Sometimes they may not make it. It just kind of depends on the severity and urgency of the bowel movement they need to have. There could be a sense of incomplete evacuation. So meaning, they needed to have a bowel movement, they had a bowel movement, and it just doesn't feel like they got everything out or there's more coming. This can cause sleep disturbances if they happen to have an episode, overnight or for a few days. Then they're going to be there's going to be some sleep deprivation components. Again, I talk about trigger foods, and patients with IBS, they're going to, over the course of their lifetime in dealing with this disease process, they're going to know foods that are more offending and foods that are, quote, safe for them. And some of your trigger foods can be spicy foods. Dairy sometimes is a huge component or a huge offender for some of these patients. Stress. So if they are having a super stressful period in their life, they can have more exacerbations than if not. And then a prior episode of gastroenteritis, so just inflammation of the stomach in general, can lead to having some IBS outbreaks. There is no definitive diagnostic tool that we use for IBS because, again, there is no true evidence of an inflammation or tissue changes in the bowels. It truly is diagnosed off of a patient history and physical. So they'll go in, they'll talk to their doctor, they'll say, hey, I've had diarrhea however many times a day, multiple days per week, and it's been going on for 2, 3, 4 months, 6 months, a year. And the provider might go down, well, let's test you for H. pylori, let's test you for Crohn's disease, let's test you for ulcerative colitis. So they'll go through a whole bunch of diagnostic questioning, may or may not run labs, they may or may not do an abdominal x-ray or a CT scan, because it truly can be, okay, you eat these foods and you have episodes, so stop eating these foods and see if it clears up. So it truly can be diagnosed simply through a history and physical. So what do we do for these clients when they have been diagnosed with IBS? Dietary management is going to be huge. Having them stay away from the foods that they know are offensive to their system is going to be the biggest thing they can do. We can increase their fiber intake if diarrhea is a huge component, and avoid any gas-forming foods. We can also try some medications that can regulate stool output to hopefully minimize the episodes of diarrhea. We can also try for some psychological management as for trying to manage these symptoms. They can do some cognitive behavioral therapy, sometimes stress management, because we know a lot of times stress can aggravate this disease process. Acupuncture could be one of the things we would use, even hypnosis. There's a lot of different non-pharmacological therapies that we can try, but a lot of times they might also try a tricyclic antidepressant, because these do have components that can help, the whole serotonin type reuptake, what have you, can assist in minimizing episodes of IBS. Moving on to appendicitis. So appendicitis really is inflammation of the appendix. The appendix is a very small piece of the colon that kind of sticks out. It's only maybe 8 to 10 centimeters long. It's attached to the cecum of the large intestine. And sometimes products of digestion will empty they empty into the cecum normally, and then sometimes those will kind of back up into the appendix and they won't come back out, which causes an obstruction and subsequent inflammation. It can become so inflamed that it does rupture, and then we end up essentially with an acute abdomen. This would be why your client would head to an emergency surgery. A lot of times your kids are kind of susceptible to this, young adults. 7 to 12% worldwide, not a huge amount of people that will actually end up with appendicitis, but it's one of the first things that we think of when a client presents to the emergency room with abdominal pain. Morbidity, mortality rates, the older the client is, the higher mortality rate they would have. And it's more so related to the sepsis that can occur post rupture. So we have to be aware of that. So the causes for appendicitis, that lumen becomes obstructed. It can be a tumor. There can be some other foreign body, just wall thickening or tissue thickening, and then fecal matter can obstruct that kind of emptying, and then subsequent inflammation will develop. You'll see some distension and engorgement of the appendix itself. There will be an accumulation of bacteria, some mucus as well, that can coincide with the appendicitis. What do we see as far as clinical manifestations? The pain kind of starts off as vague. The client might complain of pain right around their periumbilical area, and it will kind of migrate. So it can migrate towards the side that the appendix resides on. They can have some anorexia, not feeling like eating. Nausea, vomiting is a fairly common symptom. And then they'll have pain right at that right lower quadrant where the appendix sits, and that's called the McBurney's point. There will be localized rebound tenderness. So when you push in, they won't necessarily have pain, but when they let go, that will exacerbate the pain immensely. So rebound tenderness, not necessarily pain on pushing in of the palpation. Fever, they may or may not have a fever. If there has been a rupture of the appendix, they could have some initial pain relief. But as that appendix is ruptured and there's fecal contents leaking out into the abdomen, you're going to have some sepsis, some infections start developing, and fever in turn with that. Complications, obviously, of appendicitis, it can become so inflamed, again, that it perforates, and that's where we have the fecal contents leaking into the abdomen. We can also have peritonitis, which we will speak more about later on. But that's essentially an inflammation of the peritoneum, or the lining of the abdominal cavity. And then abscesses are fairly common for development as well. Diagnostics, history and physical are going to be forefront. We need to know how long the pain's been going on, what exacerbates the pain, anything make it worse, bowel movement, anything like that. CBCs and a UA will help rule out if there's a UTI possibly, given that this the appendix and appendicitis, it's right lower quadrant pain. That can also be associated with kidney stones. If you've got a pregnant female, that could possibly be an ectopic pregnancy. Like, there's a whole lot that can happen in the lower quadrants of the abdomen. So a history and physical are going to help us narrow down, whether it is an appendicitis that we're possibly looking at, or if it's going to be something different. CBC, that'll show us infection risk. We would, if it's early on in the infection, we would see, the neutrophils, and not necessarily an elevated band yet, but definitely neutrophils as they're fighting any infection that's present. CT or an ultrasound, they're going to go less invasive route first. So ultrasound is always going to be the go-to. If it's inflamed enough, it will show up on an ultrasound. But if they cannot make a definitive diagnosis, then they're going to opt for doing a CT, and possibly the CT with contrast. In children especially, they're going to go the ultrasound route first because it's less radiation. If it doesn't show up on an ultrasound, they're going to have to go for the CT, but they're always going to try the route with the less radiation. And then obviously your appendectomy, they're going to do this laparoscopically, but the appendix is not really something that we need to sustain life and something we absolutely can live without. So it is easier to take the appendix out than try and relieve that impaction and have the person keep their appendix. Talking about perforations, you can see on the image on the screen, there's kind of a little puncture hole right there in the bowels, and that is a perforation. That is where, you've had an intestinal obstruction where the swelling has gotten so bad that it's perforated the bowels. Colorectal cancer can cause a bowel perforation. If they are having a surgical procedure and the surgical tools they accidentally can puncture parts of the intestines. And as we just talked about, appendicitis can also cause a perforation. This is essentially where the bowel opens up and then contents of the bowel spill out into the peritoneal cavity. And we're really going to treat this as peritonitis. The inflammation of the peritoneum, antibiotics, anti-inflammatories, lots of fluids, and monitoring. Speaking of peritonitis, so what is peritonitis? It is an inflammation. We know that the stem of the word itis means inflammation, and the peritoneum is the lining of the stomach. So when we have an inflammation of that, it's called peritonitis. So the peritoneum is really a lining of the abdominal cavity. It kind of holds everything in together. And most of the time, it's going to be a bacteria that causes the infection. Could be a fungal infection as well, but more commonly, it is a bacterial infection. You have primary and secondary peritonitis. Your primary peritonitis is really a spontaneous bacterial infection, most commonly seen in our liver failure patients, like they have ascites, they've got some cirrhosis, and that added fluid that's in the peritoneal cavity just really creates that perfect environment for bacteria to grow and cause an overall infection. A secondary peritonitis is going to be when it is related directly to a perforation of some of the one of the abdominal organs and the spillage of the contents out into the peritoneal cavity. So your ruptured appendix and the contents spilling out, that's going to cause secondary peritonitis. If we have a gastric or duodenal ulcer, that's going to cause your secondary peritonitis. Looking at gallbladder disease, which we'll talk about in our hepatic and biliary lecture. We have a severely inflamed gallbladder that can result in a peritonitis. And then we can also end up with some peritonitis if we have some abdominal trauma. So say the client was a victim of a gunshot wound or a knife wound. Anything that penetrates that abdominal cavity causes a puncture in the peritoneum. That just opens up a gateway for bacteria to come in, but again would be a secondary peritonitis. Dialysis patients, I know we'll cover peritoneal dialysis in your renal lecture, but peritoneal dialysis is where there is essentially, we've got a port that goes into and out of the peritoneum. So fluid, they will infuse fluid into the peritoneum. It'll sit there for a period of time. There is a diacylate change. So toxins will come into the fluid, and then that fluid will be drained from the cavity. And that's what peritoneal dialysis is. But because we've got a route into and out of the peritoneum, that leaves a chance for a peritonitis. So patients who have or who are undergoing peritoneal dialysis are also at risk for secondary peritonitis infection. What are some clinical manifestations of peritonitis? Abdominal pain is going to be the biggest component of peritonitis. They're going to have tenderness over the specific area involved, but it also can be some generalized abdominal pain depending on how severe the inflammation is. They will also see some rebound tenderness, some muscle rigidity, maybe some muscle spasms. Depending on the severity of the infection, you'll see some abdominal distension. If they are a liver failure patient, you could have some accompanying ascites as well. And then because it is an infection, fever is also going to be a component. As our body starts fighting the fever, we're going to see some tachycardia, some tachypnea, definitely some nausea and vomiting, some altered bowel habits. And then our major complications are associated with an untreated or prolonged infection. We can see some hypovolemic shock if we have hemorrhaging. The perforation is also hemorrhaging, and we're hemorrhaging into the abdominal cavity. Say it's caused a septic infection. We maybe have some abscesses present. We can have a paralytic ileus, and then acute respiratory syndrome or ARDS could also fall in the way of a peritonitis. This can be a fatal infection if it's not treated. Think about how many things are in the abdominal cavity and how bacterial infection can really run rampant. So if we don't treat it and treat it early, these patients could have very poor outcomes. So clinical management, we're looking at getting CBC. If we can, we're going to aspirate some of the fluid that's in the peritoneum. We'll send that off for diagnostics. An abdominal x-ray can be beneficial if the swelling or inflammation isn't too severe. The more swelling that's present, the less we're going to see on an x-ray. We might need to move to an ultrasound or a CT, and a CT with contrast. Peritoneoscopy can help us kind of see what's going on inside. Surgical interventions, we got to get the fluid out of there, and if it is a perforation, we're going to need to drain that fluid, get any of the content, the stomach contents out, and then repair that perforation. Nursing diagnoses associated with peritonitis. Acute pain. These patients are going to have a lot of pain, so that's going to be one of our primary nursing focus. Also, a deficient fluid volume. If they're hemorrhaging, or maybe they have a bowel obstruction that perforated, and we know that they were fluid volume deficit or electrolyte imbalance from the get-go. We're also looking at an imbalanced nutrition, so they're not getting the nutrients that they need. And then anxiety is also going to be a huge component, not knowing what's going on, how are we going to treat it. So communicating with your patient, communicating early and often is going to help minimize anxiety levels for these clients. Moving on to inflammatory bowel disease. So this is a little bit different than irritable bowel syndrome. This is actually a disease process that we can tie to the bowel habits that are going on. As you can see by the image on the screen, we have an inflamed section of tissue, and then we have a normal section of tissue, and the normal section is just a little bit more dilated than the normal section. So really what inflammatory bowel disease is it's a chronic inflammatory process of the GI tract. They can go through periods of remission and periods of exacerbation. Crohn's or ulcerative colitis are the two disease processes that fall under inflammatory bowel disease. And we don't really know why these clients end up with IBD, but we will do our best to manage the disease process and give them some relief if possible. Some etiology of irritable bowel disease or inflammatory bowel disease, excuse me. It possibly does have an autoimmune component. Usually it is diagnosed in the teens or maybe early 20s. Quite a bit of people will end up with some form of inflammatory bowel disease. It's usually like maybe 1 million Americans will have it. Usually there can be a genetic component. So if mom or dad has inflammatory bowel, then it's likely that at least one of their kids would have inflammatory bowel as well. It is more prevalent in white and Jewish descent, and then again the family history of it. You can see in the image that there on the left side of the image is a healthy colon, and on the right side of the image is an ulcerative colon. So the healthy colon, it's open, the tissue is nice and pink, looks well, good blood supply and everything. And then the picture on the right, that's the ulcerative colon. It is swollen. There's some narrowing. What you can't see really well in this image is there's probably a whole lot of bleeding associated, because one of the biggest components of ulcerative colitis that is different from Crohn's is there's a lot of bleeding. So the ulcers, the ulcerations in ulcerative colitis actually cause bleeding. So here's the differences with Crohn's disease. It's all layers of the bowel. It can be from the mouth to the anus. Any part of the intestines can be, or the GI tract can be impacted. It can skip lesions. So what that means is you'll have a period or a portion of bowel that is impacted by the disease next to a portion of healthy bowel next to a portion of diseased bowel. These can have some deep and longitudinal ulcerations. It can even get so severe that there's penetrations or perforations. There can be strictures as well. The swelling gets so severe that you have the stricture that can then lead to a bowel obstruction. And then there's an abscess that can form and leak into the peritoneum. It can also lead to fistulas. They can end up with fistulas between the bowels and the urinary tract. So that would be a extreme complication of the disease. With ulcerative colitis, it usually starts in the rectum and moves inward towards the cecum. It has ulcerations in the mucosal layer. These ulcerations can bleed, so that's going to be your biggest difference. This impacts water and electrolytes being able to be absorbed in the GI tract. They can have lots of diarrhea with large fluid and electrolyte losses. The difference between ulcerative colitis and Crohn's is ulcerative colitis is mostly diarrhea, where Crohn's really can alternate between diarrhea and constipation, but you'll see the bloody diarrhea with ulcerative colitis. All right, moving on to clinical manifestations of inflammatory bowel. So diarrhea can be a component of both. You may see constipation associated with Crohn's disease, but the diarrhea component, it's going to be common in Crohn's, and but not super severe and not bloody. With ulcerative colitis, it's going to be severe bloody diarrhea. So again, that's the biggest difference between the two. You could see some blood in the stool with Crohn's, but it's not as common as ulcerative colitis. There can be weight loss with both, because we have the issue with intake, the issue with absorption. Abdominal pain can be associated with both. Fever, fatigue, depending on if there's, the infectious process along with it. Fatigue, if the nutritional intake is not what it needs to be, they're not getting what they need. Fatigue can be a result of that. You could end up with a toxic megacolon, possibly, if there's an obstruction significant enough to cause that much of a dilation in the bowel that's unaffected by whichever inflammatory process is going on. Perforation can happen, hemorrhage related to the perforation can happen, or if the ulcerations in the ulcerative colitis are bleeding enough, that's a source of hemorrhage as well. So all of these things we need to be aware of. There could be a pyelonephritis actually occurring with ulcerative if we're worried about the bacteria kind of crossing over into the urinary tract and backing up into the kidneys. Nephrolithiasis can also be something we could see. Because both of these are an inflammatory process and there's likely an autoimmune component, you can actually see some arthritis diagnoses coming along with it as far as a systemic complication is concerned. So again, complications, we're looking at hemorrhage, strictures, perforations, possibly fistulas. Like I mentioned with Crohn's, you can end up with a fistula between the GI tract and, the urinary tract, for example. If we have enough of a stricture and impending, bowel obstruction, then you have clonic dilation proximal to the obstruction. Nutritional problems, we've got, intake, absorption, problems like that going on. Things that can happen systemically, again, arthritis, eye inflammation, skin lesions can happen, thromboembolisms, and even kidney stones can be systemic complications we would see tied to the inflammatory bowel process. So how do we diagnose inflammatory bowel? We can start by ruling out any other causes. So say they've had some IBS symptoms for quite some time. We've tried some remedies, but now the symptoms are either getting worse or they never improved from the beginning. CBC can give us a lot of information, electrolyte status, if they have a low albumin levels. SED rates, looking at stool cultures, a stool culture can give us that diagnosis between Crohn's and ulcerative colitis. We can also do a sigmoidoscopy or a colonoscopy. The benefit to those is we will also be able to pull tissue samples, because a lot of times we might be concerned that there is a bowel cancer coinciding with these inflammatory processes. And if we're looking at, some possible pseudopolyps or anything like that going on, we can pull tissue samples and send those off for biopsy. We can also do a barium enema, which we know that same as a barium swallow, it will just light up parts of the intestines and highlight abnormalities. Collaborative care, we are looking at how we can rest the bowel. So these guys are going to be NPO possibly. We're going to need to drop an NG tube to manage that. Controlling inflammation, if there's an infectious process as well, we're going to look at that. Correcting malnutrition. If we cannot feed these patients, they might be a candidate for short-term TPN use. If it's stress related, we know that inflammation can coincide with psychological stress. So alleviating stress, really focusing on symptom management and relief of symptoms, and then anything we can do to improve the overall quality of life. These are chronic diseases. We can manage symptoms, but there is no cure for them. And then Crohn's disease, either of these inflammatory processes really can end up in a removal of part of the colon and ending up with an ostomy. So that would be life altering and something we would need to do education with as well. So clinical management, aminosalicylates, antimicrobials, corticosteroids for inflammation, some immunosuppressants if it truly is an autoimmune component, and then targeted therapy. So if certain medications work better than others, certain treatments for certain patients are going to be that targeted therapy. Nutritional therapy is going to be huge as well. If we cannot manage it with diet, lifestyle, and medication interventions, then we're looking at surgical interventions, doing either a partial or total colectomy, proctocolectomy with either a permanent or a temporary ileostomy. And then, if it can be reversed, we can reverse it at a later time. A lot of times with Crohn's disease, they might have to, we're going to remove that section of the bowel that's not, that's inflamed and, but it's next to two healthy sections of bowel. we can connect those healthy sections of bowel. They'll have a temporary ileostomy that we can reverse a few months down the road. But that is not to say that they will not have a recurrence of the disease and end up with a second colostomy or ileostomy, and maybe we can reverse it again, but eventually they might end up with a permanent ileostomy. You remember back earlier when we started talking about inflammatory bowel disease, I said that the common onset was in maybe the teens or early 20s. Geriatric inflammatory bowel disease is so they survive their early 20s into 30s without having an inflammatory process, and then they begin to have issues in their 60s, and it is essentially a geriatric onset of inflammatory bowel disease. In these cases, the colon is more often involved as opposed to different parts of the bowels and the GI tract. They're still going to have diarrhea. They're going to be significant for imbalanced nutrition. Remember, the geriatric population, we've got less physiologic reserves. So we are less able to compensate for excessive diarrhea, and will need to be on high alert for fluid and electrolyte replacement. And then if it is an ulcerative colitis and they've got a hemorrhaging component, then we're looking at a decreased ability for oxygen transport and perfusion. Anxiety, ineffective coping, they've lived a pretty good part of their life without any issues, and now they have a diagnosis that is essentially life-altering. So ineffective coping, we can kind of implement some measures for that as well. All right, moving on to diverticulosis and diverticulitis. In order to start talking about this disease process, we have to first understand what diverticula are. So the diverticulum the diverticula are these little kind of lumens in the bowels that kind of are sac-like. So I'm going to flip to this picture real quick. So this is the interior of the colon, and you see right here these little waves right here. This is diverticula. So when we have diverticulosis or diverticulitis, this right here is essentially a diverticulosis. So we have this little outpouching that's just, there's a particle of, food or stool or something in there, but it's not inflamed. Diverticulitis is when it becomes more inflamed. So diverticula are normal. Diverticulosis is when we have essentially a herniation of this lining without subsequent inflammation. And then diverticulitis is when we see inflammation associated with it. So we'll see about maybe 65% of the population will end up with a diverticulosis or diverticulitis. Once you've had diverticulitis once, your chance of getting it again increases. The ascending colon, the reason why it affects different parts of the colon, we don't really know why, but in the sigmoid colon diverticula, there's higher pressure, so they think with that higher pressures causes those herniations, or there's possibly a deficiency in fiber intake, or maybe there's a muscle mass or collagen loss that is associated with aging process. So you would see this in the older populations, not necessarily, this isn't our teenage and early 20s. This is our older, 40s, 50s, 60s that would end up with this diagnosis. So some pathophysiology, we end up either acute or chronic, but essentially it is the inflammation of these sac-like herniations. So if it's acute, then we may or may not be looking at hemorrhage and perforation, generalized peritonitis, again, the inflammation of the peritoneum. If it's chronic, we could end up with strictures, an abscess. The abscess could lead to perforation. We could end up with some fistulas. If we're looking at a stricture, there can also be some intestinal obstruction as well. Some clinical manifestations, they really, if it's diverticulosis, they really can be asymptomatic. But if there is pain associated with it, it's just your general abdominal pain. It might be isolated to the area that is inflamed. There can be some bloating and some flatulence or change in bowel habits as well. If we're looking at, a perforation with peritonitis, symptoms are going to be worse. If there is an abscess, again, symptoms are going to be worse. If the strictures associated are enough or are severe enough, then you can end up with a proximal obstruction as well. Some clinical manifestations that we'll see, again, they sometimes can be asymptomatic. They won't have any symptoms, especially if it's a diverticulosis. Possibly chronic constipation would be the most common thing that would precede actual development of diverticulosis, but really they can be asymptomatic or have just some mild symptoms, some mild changes in bowel patterns, but nothing significant enough for them to seek treatment. If you look at this image, you can see the smaller outpouchings, that's the diverticulosis, and then on the right side of the picture is a diverticulitis, and that is just that outpouching that has become severely inflamed. Your pain is going to be localized over the area of the involved colon. Left lower quadrant pain, there could be some fever. Anytime we have a inflammatory process, there can be associated fever. White blood cells are going to go and fight that inflammation, so we could see some leukocytosis. And then if it's severe enough or there's maybe an associated obstruction, you could even palpate a mass. Older adults could be afebrile with a normal white blood cell count and possibly little to no abdominal discomfort. So if we are suspecting this at all, your diagnostic tool of choice is going to be an abdominal CT scan with contrast. They can try, they can try an ultrasound, but really your diagnostic of choice is going to be the CT with contrast. We can do a colonoscopy as well, but definitive is going to be the CT scan with contrast. History and physical are going to be important. Doing a stool sample, testing for blood, abdominal x-rays, chest x-rays, CT scan preferred, oral contrast versus IV contrast. We need to highlight the GI tract, and the best way to do that is the oral contrast. We could talk about a barium enema, a sigmoidoscopy, or a colonoscopy. The colonoscopy would allow us to pull tissue samples as well. And then CBC and a urinalysis are going to be other diagnostic tests that we're going to run. As far as clinical management, the goal is rest. We want to get the bowels to rest so that hopefully the inflammation can decrease. High fiber diet, fruits and vegetables, decrease their fat and red meat intake. Physical activity can help with motility, stool softeners. Nuts and popcorn, they can be eaten, but eaten with caution. They can actually have a protective effect against the diverticulitis. We don't want situations of increased intra-abdominal pressure, so straining, vomiting, bending, lifting, restrictive clothing. And then if obesity is a component, trying to support weight loss can be important as well. Moving on to gastric cancers and colorectal cancers. So men are at greater risk than women for stomach cancers. Your Asian, Pacific Islanders, Hispanic, and African Americans, they start out or are most commonly adenocarcinomas. They can really be anywhere in the stomach, and there's often some few symptoms, so they aren't caught early necessarily. Uh, you may or may not be able to palpate them depending on their size. And there could be some ascites and hepatomegaly if the tumor has metastasized. We can do an EGD with biopsies and surgery to remove, chemotherapy, radiation, partial or total gastrectomies. And then looking at colorectal cancer. So this is the third most common site for a cancer diagnosis. Age is going to be your biggest risk factor. There is a genetic component to this type of cancer. It is also an adenocarcinoma. And then your location of the cancer really will lead more towards the type of symptoms that they're going to have. There could be some anemia, some anorexia, weight loss, fatigue. We can do a stool sample testing for blood. We can do a colonoscopy that will allow us to pull tissue samples again. We can also do surgical removal. We can treat with chemotherapy, radiation, and ostomies if need be, just depending on the severity and route of treatment prescribed. And that is a wrap on all things lower GI. If you have questions, feel free to send an email or schedule office hours. And I look forward to seeing you in live lecture. Have a great day, guys.